And then maybe I can see if, I think it works now. Can you see that now?
Yep.
Okay, great. Okay. Is it big screen now?
Yep.
Okay, great. Oh, but then you see. Okay. Are you going to be here the whole time, Danielle?
I might step out to grab my dinner.
Okay.
But
you're not interested in MIS?
You text me if there are any issues. I'll be
Okay.
around.
Yeah, sounds good. Thank you. Why is Tommy in this chat?
He was here so early.
Why is Tommy here?
Tommy was here before I was here. I was like,
Gosh. Oh my gosh. I think the staff are just logging on. Is this the first session, Danielle?
no, it's the third.
Okay, thank God. Oh, no problem then. It's all good. Someone logged in his iPhone. Okay, no, it's actual person now. Thanks everyone for being here on time. I don't know how many we're expecting. We're just waiting for Dr. Neville and Dr. Colsvarty to join, but welcome. I'm Alex. I'm one of the R5s here at in Ottawa. I see some people on. Maybe we can, I don't know if you guys have been attending some other sessions already. This is the first one that I've attended. So I'm not really sure how the format usually works. But maybe we can do like shout outs. Those are always nice. Like maybe where everyone's from. So do we have anyone here from BC? Nope. Okay. Anyone from Alberta? Oh, I see a clapping. Is that a yes? I guess so. Looks like Patrick is from Alberta. Okay. Anyone from Saskatchewan? Nope. Okay. Manitoba? Nope. Ontario? You can use your mics if you want, or raise your hands if your video's on. Oh, I see a thumbs up. Veronica Chan. Awesome. Anyone from Quebec?
Yes.
Oh, yay, quite a few hands. Awesome. Welcome. And a thumbs up as well, I see. Okay. Anybody from Newfoundland? Okay. New Brunswick? PI? Okay. Okay, that's pretty much it. So, and some people are undecided where they're from, I guess. Um, or do we have international students also, actually? Oh, somebody raised hand. Oh, cool. Awesome. Welcome again. I see Dr. Colsfari is on now. We're just waiting for.
Thank you for starting. I was just trying to organize some stuff.
No problem.
Perfect. All right. So is Dr. Neville on or not yet?
Not just, I don't think I see her just yet.
Not just
No, I'm here.
yet.
Oh,
Oh,
what?
she's there.
Where did I miss her?
Perfect. She's just being.
I just logged on.
Oh, I see you. Hey, Dr. Neville.
Hey guys.
Okay. All righty. So I think I saw Danielle. Is this everybody kind of what they were expecting, or should we give people a few more minutes?
How about we start at 8:05?
We'll start at 8:05. Okay, sounds good. I'm gonna mute myself for a couple minutes then. Better that.
It's only one more minute till 8:05. I'll make this bigger.
So I'm going to say something unpopular. If you guys could turn on your cameras, I do think it actually makes these things a lot easier to kind of feel a little bit more more real. And like I said, I think it's a little bit hard to see the monitors and you guys, but please feel free if you have any questions or anything like that. We just have a couple of slides to guide us. And then of course, if you guys want to talk about anything, we'd be happy to. It's 8:06, so we'll start if that's okay. So welcome everyone. Thank you so much for taking time out of your evening. I know this is a busy time. I'm Nicole Colesbury. I'm one of the bariatric and foregut surgeons here at the University of Ottawa. And we're doing a bunch of these sessions for obviously to try to replace some of the interactions you would normally get through either your electives or when you come here in interview time and so on, which obviously we can't this year because of COVID. We were asked to do a session on MIS because my understanding is the first time there was one of these sessions, there were lots of questions for MIS, and I think I was asked to do it because I'm on the CARMS committee. So I did what I did best, and I recruited some friends to help me to actually make this a bit more interesting. So Dr. Amy Neville is joining me, who's one of the other bariatric foregut staff here, as well as Alexandra Chow, who kindly started this, who's one of our fifth-year residents and will be starting an MIS fellowship. And like I said, I think the whole point of this is we'll tell you a bit of our program, but then if you guys have any questions, we're happy to answer them. Oh, Alex, I can't move the slides. Can you move them or let me?
I got it.
Them?
I'll move them. You cannot.
got it.
Apparently, I have all the powers. So
You do have yeah, you do. I hope
okay,
you
one
have
second.
the most recent.
I will move. I think so. It's the internet one. Well, we'll see. We'll see.
I made another change, but that's okay. So the slide here, I'm assuming you guys all have seen the website. Presumably that's how you knew to sign up for this. But if not, this is actually one of our residents that now in R2 that has revamped our website. There's lots of information there. I highly encourage you to go if you have not. And I think it's got some really nice kind of more candid information about both our trainees and some of the staff, as well as important dates and frequently asked questions and things like that. So again, I'm assuming everybody knows about this one, but and Danielle, thank you for putting it in the chat should you need it. But if you don't, then try it out. Okay. So why MIS? This is probably my favorite quote about MIS. It's from a slightly depressing book, so don't read it until you're done residency. But what he says is almost any abdominal operation can now be performed laparoscopically, which is Greek for much slower and involves inserting tiny cameras and instruments on long sticks through little holes. It's fiddly. It takes a long time to learn. Recreate the experience for yourself by tying your shoelaces with chopsticks with your eyes closed in space. So that is actually, I think, a little bit of how laparoscopy feels early on. I think, and we'll talk about this, our program has the advantage that there's a lot of minimally invasive surgery that happens, probably just by nature of some of the programs we offer, and also we have a relatively young staff, so I think people are pretty comfortable. But it also means that you as residents here actually get a lot of MIS experience, so certainly more than I did in my training. And although initially it feels a little bit like this quote, with time you can get actually quite comfortable, and laparoscopy can feel, or minimally invasive surgery can just feel as part of your armamentarium without feeling super foreign and difficult. Next slide, which I'd meant to move later. So just to give you an idea, so some caveats, I wanted to give you some numbers so you know what we mean about a large exposure. So I did pick numbers from 2019 because I didn't think looking at our volumes of COVID was fair to anyone. So we've certainly lost a lot of cases, as everybody did, and hopefully we'll catch up. And these are all from the Civic campus, so it doesn't include two of our other campuses. But this is where the majority of bariatric surgery, of MIS surgery happens, where bariatrics happen. So this was, we do 544 bypasses in that year, and then we do some sleeves on top of that. They did 77 laparoscopic colon resections. So that number is in fact greater within the program because the general campus also has a colorectal service with a fair bit of laparoscopy, as do our community sites that residents rotate through. The laparoscopic inguinal hernia volume looks low for that year. Again, it's the Civic campus, and a lot of these actually happen at the Riverside Hospital, which is our day surgery kind of hospital. Also, Dr. Neville, who's here, who probably does the most out of these in our program, was on maternity leave that year. So it negatively impacts our numbers. But I can tell you, I think in the last month, she's probably done close to 10 lap inguinal hernias. And lapadrenals, you know, our volume is low, but it's respectable for what general surgeons do. So that year was about 7. I think this year we've done 5 already, and we have a few more in the works.
Is this the right
Dr.
slide?
Neville, take it away.
Okay.
Now I feel unprepared because you told me you didn't put my slides in.
There's 3, so I don't know. I hope that's right.
No, I did. I just meant to move the slide with the numbers at the end of your section because I thought it made more sense. But then Alex already had uploaded this because she's prepared.
Sorry.
Perfect. Good. So we're all super prepared. Excellent. So hi, everyone. And thanks, Dr. Colesberry, for running this whole show. So my name is Amy Neville. I've been at the Ottawa Hospital for about 8 years now. And I do mostly minimally invasive surgery and bariatrics. So what I just wanted to talk about for 3 short slides is a little bit about what you could expect as a resident in your dedicated MIS blocks. But I also want to be really clear that MIS is really pervasive in general surgery now. So, I'm going to talk about what you would see when you're on our team, which is Team E at the Civic Campus. But, we do tons of laparoscopy on ACS. I was on ACS last week and did, a laparoscopic perforated duodenal ulcer. We did a laparoscopic incarcerated femoral hernia. So we do lots of interesting laparoscopic cases in other settings as well. And as Dr. Colesvary mentioned, tons of laparoscopic colorectal surgery. But with respect to our team, which is really the dedicated MIS group, the first thing I would say is we do tons of bariatrics. So that is a plus for some of you. Some of you may think that's a little bit boring or it's not your interest. But regardless of whether it's your interest, the skills you can learn doing laparoscopic bariatric surgery are super applicable to the real world in general surgery. And they're advanced laparoscopic skills, so they're always helpful. So we do in the bariatric program somewhere between 550 to 600 cases a year, which basically comes out to 4 days a week of bariatric surgery with somewhere between 12 to 15 bypasses a week. So that's a pretty big volume. Some of you may be training at centers that do a lot of bariatrics, so you're used to it. Some of you may be training at centers that do no bariatrics, so this will be interesting and unusual for you. And because we have such a big volume, it really leaves a lot of room for all of our learners to be involved. So we do have a bariatric surgery fellow, but as you can imagine, they become proficient very, very quickly, which leaves a lot of room for the residents to participate. So if you're a junior resident on our service, what can you expect? Obviously a lot of time assisting. That's normal when you're doing really advanced cases, but assisting in a gastric bypass is a really active process. So lots of assisting. We do expect our junior residents by the end of the rotation to be suturing the enterotomy for the jejunostomy, so laparoscopic suturing, which we also do expect you to go to the lab and practice too. So you go to the lab, you practice, and when you're on our team, we let you actually sew some bowels. So that's fun for most juniors. And most juniors can do part of the dissection, sometimes even most of the dissection in a sleeve gastrectomy. We don't always get senior residents on our team, but when we do, we typically let them, like Alex did earlier this week with me, or last week, I should say, basically set up, staple, suture the jejunostomy, so do the whole intracorporeal small bowel anastomosis, which, like I said, even if you don't want to do bariatrics, being able to do a laparoscopic intracorporeal anastomosis is a very useful skill for your future. Residents that are keen and spend a lot of time on our service will eventually be able to make the gastric pouch. They can typically do a complete sleeve gastrectomy, and then do some of the other procedures we do. They're kind of accessory operations in bariatrics. So things like, laparoscopy for internal hernia, laparoscopic feeding tubes, all those fun things. So what else do we do? So we don't just do bariatrics. We do a lot of bariatrics, but we also do some other stuff. So Dr. Colesvary does most of the solid organ surgery, so she loves adrenals. So we do an increasing amount of adrenals every year. She also does spleen surgery. And then we do a pretty big volume of foregut surgery as well. So anti-reflux surgery, paraesophageal hernias, things of that nature. And those are things you really don't see all that commonly in general surgery because they're relatively rare diseases. But you will see a very decent number on our services. It's obviously all done laparoscopically. And then how much a resident does obviously depends on their level. These are relatively advanced cases, but they're super interesting to see gastric surgery and hiatal surgery. So that's a big part of what we do. Yeah, go ahead, Alex. And then just a few other kind of random things. So we do a ton of upper endoscopy, which, residents often feel like it's easy, but it's actually really interesting when you do a ton of upper endoscopy with pathology or in patients who've had previous surgery. So we typically do our endoscopy days on Friday. It's 18 scopes a day. So when the residents come with us, they get to do 18 G scopes in a day, which is really high yield because it's a great time to just practice with a ton of repetition. And that is shared with a resident on endoscopy. But if you're not doing it on our team, you'll eventually do it when you're on your endoscopy block. So tons of practice for upper scopes and seeing tons of different foregut anatomy and pathology. On our team, we have weekly fellow rounds. So the fellow basically presents an educational topic every month. Sorry, not weekly, monthly, which is part of kind of a bariatric curriculum. So interesting to learn about. Because no matter what you do, you'll have to know something about bariatric surgery. It's so common these days. And we do have a research group. So we have monthly research group meetings where we go over ongoing projects. The residents come and present what they're doing. We kind of check on how things are going, provide feedback on abstracts and RED submissions. And so if you have any interest in doing research in this realm of general surgery, so MIS or bariatrics, we definitely have a good setup to help you get going on that. So that's kind of the overview of what we do on our team. And like Dr. Colesbury said, we can take questions at the end, obviously.
All right. So I just have a couple slides just from a resident's perspective going through the program. This is my last year. So, you know, MIS is a very interesting question. By the time you're done with your training, I'm sure all of you will match to a great program, and by the time you're done, you know, you'll all be proficient at laparoscopy for a lot of operations. And then there are other skills that, you know, take a bit more practice and training. But overall, like why I think MIS is great is this is the first part. I'm sure you all know what it's like to be in an OR where you're like the fifth, sixth assist, like at the end of the bed. You only see the back of the very tall person's head. They're like, do you see that vagus nerve? And you're like, I don't know what you're pointing at, you know? So we all know what that's like. And the reason why MIS is great and a place where we do a lot of MIS is a great place to train is because even when you're starting out or you're in a very advanced procedure and you maybe don't have your hands in everything, but the fact that this procedure is done laparoscopically means that it's a huge learning opportunity for you, even just to see anatomy that you never see before. Like you're never going to see certain areas of the body from that perspective and in that much detail and clarity. And so I find that that's incredibly useful, especially when you're starting out and you're not necessarily operating a lot, but even getting familiar with the spaces that we commonly work in general surgery from every angle is very helpful, because as you know, anatomy is part of everything we do. Another reason why I think MIS is great is because there's a role for everybody. This might be dated for some people, but it was very popular when I was young. But so, you know, kind of what Dr. Kolsavari alluded to and Dr. Neville alluded to, everybody has a role in the operations we do. And I find that that is a mentality that's held across all the groups, whether you're in colorectal or HPB, and especially for all the lap procedures. So, you know, you're going to be very, you know, most staff are very good at debriefing before surgery. You know, what do you want to learn today? What do you want to do today? What do you want to improve? And if you express interest that you want to do this part of an operation, then they'll be like, okay, right on out. We're going to budget that time for you. We're going to walk you through that part. And so, you know, regardless how complex this operation is, you know, everybody has a role, and that's awesome. And then obviously why MIS is great is I think I'm a bit biased, but obviously I feel like MIS is the future. It's very rewarding to do very complex operations through tiny little holes and see patients recover quickly and just be so, you know, shocked that you were able to do something like that as if you were never there. So, you know, I think it's a great time to be training. It's a great time to be involved in like MIS procedures, and it just keeps evolving and getting more and more impressive. And so I think having a good foundation as a resident really sets you up to be able to tackle that kind of stuff in the future on your own, and also to continue to challenge yourself and improve in those areas. So in terms of why I think the MS program and why, you know, our exposure here in Ottawa is great. So the first part is we have very dedicated junior and senior skills labs, which I think is really important through the simulation center. And it's split between juniors and seniors, which is great because then all the sort of skills that are practiced are targeted toward your learning level. So as a junior, these are some of the juniors at the time. They're no longer juniors now. But as a junior, Almost once every month to 1 to 2 months, you'll have a dedicated at least half day or full day where you attend the simulation center, and you do various stations that test different areas of both laparoscopic skills as well as open skills, but a lot of laparoscopic skills. So for example, in this picture, this is me and Heather, one of my co-residents, and these are some of the lap boxes we were training on. Here down here, this is Carlos and Raj, and they're doing a gallbladder with like by themselves, the two of them. Obviously it's a pig model, but it's a pretty close resemblance to doing on a real thing, as close as you can get as your junior. So, you know, you get to set each other up, assist one another, and do different parts of the case. Here they're doing some suturing, and then there are other stations where you learn to run bowel and retract and that kind of thing. So the junior labs I find very helpful, especially since they happen quite frequently. So you have a chance almost every month or every month or two where you can just go ham at the simulation center. And in addition to that, the sim center is very accessible. It's on the civic campus, and you can go in at all hours of the day, even past hours, which I find is very helpful, because obviously not everyone can go to the simulation lab in the middle of the day. So you can always just email the ladies in the front, and you can set up to go at any time after work. Like you can go like at 8 o'clock in the evening and do it all night if you want. It's less sort of you have a card access building. And also you can even take the trainers home. So you can take the FLS box home or the lab trainers home to practice as well. So I just find it's very accessible. I know at some other places I've been, sometimes the sim center is sort of out of the way, or like, it's quite hard to access, but I find that if you were interested here, there's always ways to practice. And then in terms of the seniors labs, which I didn't show here, but the senior labs are the same. We typically have a lab every 1 to 2 months. And as a senior, it's really awesome because you do cadaver labs, which are great. But in terms of laparoscopic skills, we do pig labs as well. So you can perform laparoscopic procedures on a pig, which is pretty interesting. So we get to do those. Those ones are typically, I think, 4 times a year. So I think the first time I even tried to take out a kidney was on a pig laparoscopically. Had no idea what I was doing, obviously. But there's staff that attend these, and they walk you through the procedures, and you get to do it with your colleagues, and you assist one another. So it's a really great experience as well. The second part of what's great in Ottawa, and I think Dr. Colesford already alluded to this, is we're a very high volume bariatric center, and that has lots of implications for your experience. Bariatrics is becoming a major specialty, and you're going to see it anywhere you go. And it's also a big part of the exam in the future, and also what you're going to see on call. You're going to have patients, not just patients who have had bariatric surgery, but patients who are obese, and when you have patients who are obese, there are many considerations in terms of performing a procedure laparoscopically, for example, entry for one, that is very nuanced and is very important. And depending where you practice, if you don't have necessarily the skills to be able to adapt or recognize that this is going to be a challenging situation, it can be very difficult. So I think if you work at a center where you do a lot of bariatrics, you get very comfortable tackling any difficult abdomen or difficult body habitus or difficult conditions. So that's really important. And then also when you're on call, you're going to see all kinds of bariatric pathologies that you can encounter. And it's really nice to be able to see that in real life as a resident, so that when you go to the exam, it's not something that you've never seen or never dealt with, which can be the case in some places, depending, some provinces who don't have as robust a program there. And then finally, our staff, you've had a little bit of a taste today, but our staff here are great. They're very well connected. You'll find that the MIS community is very small across Canada and even in the States. and our staff are very integrated and supportive. They want to be at the forefront of what's new and exciting in MIS and in bariatrics, and things like our research and having new ideas of how to do things and how to improve things is a reflection of that. And it's good to be at a place where you have people who are able to put in a good word for you and also are able to support you through your goals, your career goals, and what you want to do in the future. And I think they've done a great job because we've had quite a lot of success in Ottawa. So just one caveat, shout out to my boy, Matt Mosler here. So he's one of my co-residents, and he's been at the National Suturing Competition 3 times. The first in the semifinal, the second as the second runner-up, and last year he was the champion. We've been doing pretty well. Did I lose my screen? Maybe not. Okay, so we've been doing pretty well. I think our residents are very proficient laparoscopically. We're very comfortable. We are showing the world that, or well, at least Canada, that we can do it. And then we've had a lot of success with obtaining fellowships in MIS last year and the year before. But so myself, I'll be going to Edmonton for my MIS fellowship next year. Matt's going to be going to St. Mike's, and Nada's me spending some time in Humber Hospital as well when we graduate. So yeah, we've piqued an interest while we've been here in Ottawa. We've had good training. We're well equipped, and I'd encourage you, if that's something that you're interested in the future, this is a great place to do it. So I think that's it for this presentation.
Thanks very much, Alex. So I'm trying to see the best way. Maybe we'll end the presentation so everybody can see each other if they wish.
Let me
think,
try
like
to
I said,
unshare the screen.
Yeah, I think the goal to these little sessions that you guys are having is not to be too onerous on your schedule, but rather offer you a taste of, and I think other programs are doing this as well, what you can actually expect. We're happy to answer any questions if anybody has them. If not, this will be very short. Like I said, what I think, and I think we've all said this, is MIS is just, it's one way of doing things. It's really a cornerstone of most general surgery practice these days, even trauma these days. We do things MIS occasionally, and we do a lot of MIS here. And I do think our residents, like I said, and like Alex and Dr. Neville did as well, get a lot of experience just by virtue of the people that work here. I'd say at least probably half of the perfed ulcers and things like that get done lap. It's just the exposure here is very good, and we're all pretty passionate about teaching those skills and enjoy it. Any questions? Feel free to type them up or write them in the chat. We'll give you guys another couple of minutes.
You can speak up also.
Yeah.
That's fine as well. We're here all night, folks. Maybe not all night. Maybe not all
Maybe
night.
not. Maybe not all night. Some of us have jobs in the morning, Alex.
We're operating tomorrow. It's gonna be great. It's gonna be great.
It's gonna be fantastic. Lots of interesting cases. Oh, so can you tell us what are the rotations in the first year as a junior? I wonder if Alex, or I'm gonna out him, Tommy's on this call as well. Nadia, do I see if you?
Oh, really?
It changes, it varies. I don't know, or is this another? There's somebody on this call named Nadia Khan. I don't know if that's our resident Nadia Khan or a different Nadia Khan.
It's me.
Hey, Nadia.
It's you. There you go.
Hi. Hang on, I'll turn my camera on.
So they can tell you, I think it's a pretty wide exposure, and Dr. Williams, as the program director, works pretty hard to ensure everybody has kind of a breadth of exposure across the different specialties to meet all the objectives, obviously, from the Royal College, both for surgical foundations and for general surgery. But they can tell you more specifically. You don't rotate on MIS usually, although we have an R1 coming next week.
I think I did MIS every year. I've been a resident. Yeah, I think
okay.
so. The first 2 years, there are some. I think it's changed the years because it's become more tailored depending on what the residents asked for. So for example, there used to be probably about half of the first year was off service for things like medicine, emerge, GI, and some other surgical specialties but actually there was feedback from the junior residents that they wish to do less off service, and so things have changed and kind of been altered depending what the feedback was. But I would say in general, more than half of the first year is spent on service, so you rotate through any of the major sort of 4 to 5 major teams, so that'd be colorectal, HPB, MIS, surgical oncology, and breast, and of course acute care. So especially in the first 4 years, you do at least 2 to 4 blocks of acute care a year, which is super high yield and fun and exciting. And then you can also request blocks if you wish. So like, for example, you can request to do a research block, which often people do, and you can request certain other subspecialties if you like. So we do spend a fair amount of time in vascular and peds general surgery. And if you want to do more of that, then you can just request it, and they're very flexible. I don't know if Nadia or Tommy wants to add anything to that.
No, I agree with that. I think the first year is pretty variable. You spend a bit of time on acute care, and then you spend time on the elective services, and you do get to pick what you want to do an extra block in. I think mine was thoracics in first year, and I did some peds gen surge too, so it was good.
Okay, I see another question. Does the resident at Montfort have as much exposure to MIS? So the Montfort, for those who don't know, is another site we have in Ottawa. It's a large community hospital. I believe there are 2 or 3 teams there. Actually, some of our grads actually work there. And as to if they have much exposure to MIS, they do. They do a fair amount of lap colons and other laparoscopic procedures, obviously, but they're quite integrated with staff from like across the city. So a lot of the staff at the Montfort and even at some of the other larger community hospitals attend sort of the same quality rounds, like sort of where they go through their techniques, they go through the numbers at their hospitals and their outcomes. So there's a lot of crosstalk, there's a lot of quality improvement, and I know several people who have spent a lot of time at the Montfort, and it's an amazing experience because there are fewer residents there, so they get thrown in right away, and their volumes start off really high. Even as a early senior, later junior kind of a role. Nadia, have you been in the Montfort?
Yeah. The other thing too, just to add about the Montfort stream, is that it is, a separate stream. It's for somebody who speaks French, just for those of you who don't know. But it's also very much integrated in our program. So, you will do quite a few rotations at the Ottawa Hospital. So at like our main teaching sites as well. And that includes any of the really subspecialty stuff. So HPB, bariatrics, etc. So you get very good exposure for your bread and butter general surgery blocks, but a lot of the subspecialty stuff you'll do kind of in our regular program at our usual teaching hospitals as well.
I see there's a question about how many fellows we take for MIS. So we actually currently have a pure bariatric fellowship rather than an MIS and bariatric fellowship. We take 1 fellow a year. I think, to be completely honest, we're thinking about maybe having another fellow come for a combined program, which a few years ago they used to. Right now, the bariatric fellow theoretically only attends the bariatric cases and not MIS. The reality is that what the fellow does and what the residents do are very, very different. And again, like Dr. Neville had said, simply because of the volume that we do, the fellow has become very proficient at doing the things that as a resident you might do very quickly. So you are not competing for the same thing. But right now we have 1 fellow. Even if we had 2, I really don't think it affects the resident's experience, because again, the things you're going to do as a resident, things like, sewing up the jejunal-jejunostomy, and maybe as a senior setting up the jejunal-jejunostomy, that's something that most fellows get pretty bored of doing after about a month or two in the program, just because of the sheer volume. So you're not, I don't think you're really competing with them. Generally, our fellows, I think, actually contribute a fair bit to the program. I think they're generally well liked, and they're helpful in teaching laparoscopic skills and things like that. I know in some programs sometimes there's this kind of tension between fellows and residents occasionally. In Ottawa, we have few fellows in general, and I really don't think, I don't get that sense at all. And certainly with I'm the program director actually for the fellowship. We haven't had that issue because of the sheer volume. Any other questions, guys?
And to address that
You'd like to know?
for the other fellows as well. So we do have a fellow in colorectal per year, so one per year. So there's usually 2 fellows at a time. Again, there isn't as much there's a lot of discussion and collegiality between the residents and the fellows. And because I think all the staff do a really good job of like I said, discussing through a case, like what is a resident appropriate level to do this case, which part of it is appropriate for the fellow. So I think there isn't a lot of butting heads or stepping on toes, that kind of thing, which is great because, obviously you don't want your learning opportunities to be sort of set aside, as a resident. And I would say most of the residents would not feel that way here. And like certainly when I was on colorectal this year as well for 2 blocks where they do a fair amount of minimally invasive stuff. And, I was very happy with what I was able to do, what I was allowed to do, and the parts that the fellows was doing. Sometimes you would assist the fellow, or sometimes you wouldn't do those parts, but probably wouldn't be super appropriate anyway at our level. So I think it really all works out, and we haven't had much trouble with that.
I see a question about physician researchers. So I think it depends a little bit on what the asker is asking. So there is a surgeon scientist program for residents at University of Ottawa. So that's a 2-year dedicated time, pretty much in the middle of your residency, to do CIP, which is Clinical Investigator Program. That's a Royal College accredited program. And you use that time to work toward a master's degree and complete research projects. So yes, we do have that capability. It's awarded on a competitive basis. So not everybody can do surgeon scientist. And it's typically 1, occasionally 2, but typically 1 resident per year. And again, awarded on a competitive basis. And in terms of physician researchers, we obviously have a very robust research program. So we're affiliated with the UHOI, which is the University of Ottawa Research Institute. So a number of our staff members are full professors, have research chairs. So if you're looking for an institution to do surgeon scientists, is definitely a possibility. And if you're looking for a place where you can have strong research supervisors, even outside a CIP program, then there's definitely lots of opportunity.
Natty, do you want to answer the question about trauma?
Yeah, so during our residency, so I'm one of the 4th years. During our residency, we rotate through the trauma service. And so we do have dedicated blocks where you spend an entire month or 2 on the trauma service. And that's sort of all encompassing. So during the daytime hours, you respond to trauma codes. For all general surgery residents, when you do call at the Civic campus, you're covering trauma on call. And so depending on the time of year, we get a fair amount of traumas. In the summertime, sometimes that can mean 10 or 12 trauma patients that we see between the hours of 5 p.m. and 6 a.m. In the winter, it slows down a little bit, but I would say that so far in the last 4 years of my residency, I have had quite a lot of trauma exposure, and I feel that our program trains us quite well. And it's consistent. You don't do a rotation and then not get exposed to it for months. You're just getting repeatedly, you're repeatedly seeing traumas during your entire residency from start to finish.
I saw a question about robotics. So we do have a Da Vinci robot at the Ottawa Hospital. Nobody in general surgery is currently using it. So it's mostly gynecology and urology that use it. I would say, I'm the director of the MIS and bariatric program. right now there's no good indication in general surgery for a robot in terms of outcomes, cost efficiency, or time efficiency. So none in MIS, but there is a physical robot, but we don't use it.
I've been in a case where they used a robot and there was a iatrogenic colotomy. And then they were like, we need this fixed. And then we hummed and hawed for about 15 minutes if we should use the robot to fix it or if we should bring like the laugh card out. It was, I think they ended up not using the robot to fix it. But anyway. Okay, there's a question about what does the schedule for calls and academic half days look like for residents? This is a great question. So I think I love talking about this one part, but I think a beauty of the auto program is that we don't have a lot of sites. So as Dr. Neville, Dr. Colesbury mentioned before, the Civic and the General are two major sites. The General does a lot of cancer, and the Civic does a lot of trauma and neurosurgery, that kind of stuff. So those are the two main sites. The Riverside is a day hospital, so you don't like there aren't patient staff there. So, and then there are some community sites that you can rotate through, but it's not like there aren't that many residents on those rotations at a time. So effectively, you have 5 to 6 residents per year. In 5 years, and you only cover 2 sites. So the beauty of that means you don't do that much call. So I have to say, in the 5 years I've been here, I've probably done 6 call a month, only a handful of times, which is shocking. I know. I'm sure you've heard about elsewhere, but it is quite shocking. But so in terms of calls, that's what you can expect. As a junior, typically you will do 5 call a month for sure, sometimes 6. As a senior, pretty similar. And actually, as you get more senior, often, well, the 5s are sometimes call protected as well. So, and even as a 4, like most people do 5 or 6 call a month as well. And our chief resident, does a very good job on call scheduling. They always like it's amazing how much in this program people step up to cover one another and to make sure that we all have a very like reasonable work-life balance, which is really important in a 5-year residency because it's a long road. And so I think that the chief resident who does the scheduling and also everybody who puts in input, they do a really good job to make sure that everybody has a fair amount to call and everybody feels that they're not burnt out. And they make a lot of accommodations for vacation requests, that kind of thing. It's crazy what they have to do. There's like a huge Excel spreadsheet and they can deal with all your vacation requests. It's amazing. But so I would say in general schedule, the call is very, very reasonable. Academic half day. So the juniors have an academic half day once a week. In addition, they also do principles of surgery, which is also once a week, which is shared with all the other surgical residents. And that's protected time. And the seniors have an academic half day once a week as well. And then in addition to that, there are nighttime teaching sessions, which are kind of hangout sessions and teaching sessions that the seniors put on for all the juniors. So about once a month, a senior will host essentially a teaching session. Sometimes it's at your house or well, with COVID, I guess not, but it could be at your house or a restaurant. And they lead a topic and walk the juniors, all the 1s and 2s through a topic, and they share a meal and they, talk about it. And then we also have journal clubs, at least once every 2 months, I think. Dr. Colesbury actually runs the journal club, so she can talk more about that. And then I think, are there more teaching sessions? That's probably the major ones. Did I miss any, Nadia?
I think that's it. I just add we have M&Ms every week. So morbidity and mortality rounds are every week, which are in some ways teaching sessions.
Oh, and actually, I forgot. Also, there are rotation-specific teaching as well. So, for example, if you're on colorectal, there's a teaching session once a week in the mornings that the staff put on. On breast, it's the same. There's a teaching session once a week, specific to breast topics. HBB has the same as well. So there's a lot of teaching, and you can be as involved in it as you want, and there's opportunity for you to lead the teaching as well if that's something you want to do. Yeah. Okay, there's a question about call at the Montfort Hospital. Are there more call because there's less residents for a single hospital? And the answer is no. Their Montfort residents do the same amount of call that you would at our major sites, and it's partially mandated by PARO, which is your residency committee in Ontario. So essentially, you get assigned 5 or 6 call, I believe, or even less than that. Uh, so far as I know of my colleagues who have been there. So you don't do more than elsewhere.
Do you want to take the next one, Alex, about residents teaching?
Yeah. So other opportunities for residents to be involved in teaching, for example, to medical students. So yes, definitely. Actually, they're always looking for help to do that. And you actually get a stipend, so you get paid as well. So that's amazing. So there's a lot of medical student teaching. So you can teach general surgery specific things. So they do have specific sessions teaching different general surgery topics, or you can also just do general teaching as well. So every now and then we'll get an email from the undergraduate coordinators, and they'll ask for volunteers and any residents who want to take part in teaching. And it's great. It's always, and some of them are at the Sim Center, and some of them are, virtual like this, and some of them are like in person or more didactic. So there's lots of opportunities for that. And then, as I mentioned, there's a lot of opportunities for teaching, like senior residents teaching junior residents is a big part of our program as well. So I'm pretty sure you probably do at least 2 or 3 presentations to junior residents a year or more. So that's always great. And I actually forgot to mention, there also is a mentorship program that has been happening the last 5 years, and I think it's still happening. Nadia can correct me if I'm wrong, but essentially there is a staff who's assigned as the staff mentor for your cohort year. So for example, in my year, one of our surgical oncologists was our staff mentor. And as a mentor, we would arrange in a year, we'd probably meet up 4 or 5 times, and at various locations, and it's paid for by the program. So depending on your year, our year, they always laughed at us because we like to spend the dollar bills. So we always went to all these fancy restaurants with our mentor, Dr. Nessam. And then it's just a great time for them to talk about their journey and answer questions that, you might not feel super comfortable asking when you're just starting out. And you really get to know your cohort residents as well as that one particular staff really well. And they continue the mentorship program through your first and second year, and then afterwards it stopped, but then you still do informal mentorship. But that's a really great initiative that was actually started by one of the residents in our program. She's since graduated 3 years ago now, 2 or 3 years ago. So it was one of her passion projects, recognizing that there's often a lack of mentorship in surgical specialties in general, which can be very important for just your training, and then also your career planning or just life planning. It's really nice to have somebody who's lived through it and talk to you on a very genuine personal level outside of work. And so that was a great initiative that Caitlin Champion had started many years ago. Okay. Shall I answer this question about Royal College? Okay. So it says, I'd like to ask about the mock exams the residents will do as preparation for the Royal College exam. That's a great question. We do mock orals every year. I think it's 4 times a year, at least 3 or 4 times a year. Actually, Danielle will know best. And essentially, every resident does it. You come in, usually on a weekend, usually Saturday, and you go through 2 mock oral sessions. And the scenarios are, they do tailor it to juniors and seniors in terms of the scenarios. And so those are always very humbling experiences. But they're a lot of fun, actually. And then it's always nice to then chat with your co-residents and be like, what did you say? And then you're like, oh, I don't know. And anyway, talk about it. So we do that through year 1 to 4, and even in year 5, we are considering doing that as well. And then obviously there are, we do the CAGS exam like everybody else. And for our teaching sessions, like your academic half days that I had mentioned earlier, often there are like short quizzes before the academic half day to sort of test your knowledge, to kind of identify learning deficits. So you do those once a week as well before your academic half days. Those are most of it, I think.
Yeah. And the other thing, so that, as Alex said, there's kind of a formal mock oral program that really is throughout your residency, which is a nice way to start thinking about examinship and reading up before exams and whatnot. But the R5s also, throughout their academic year, have protected time Wednesday mornings, which early in the year they typically used to do multiple choice questions together as a group, often with a staff mentor to help them through the subspecialties. And then later in the year, we often use that time to do mock orals. Or we have in the past, I should say. There was no mock orals for this year's exam, so it was a bit unusual. But basically, they usually recruit a staff every week to come do mock orals with them as practice when they're 5th-year residents.
Yeah, and it's really great. Like, staff have to take aside time to do these dedicated sessions for us. Like, we have a staff every morning for like between 8 to 12 once a week to essentially sit down and have us bombard them with all our controversies, and then have them teach us things and help us pass this exam. And you don't realize, but they have to, they either have to cancel a clinic or move around a clinic, or set aside admin time or research time to do this for us. And they're all very willing, which is amazing. And they want to equip us to pass and do well. And the other thing that's fantastic is that I think one of the strong points is our staff here in Ottawa, whatever specialty they're in, a lot of them are at the forefront of innovation and of current guidelines for all types of specialties. So as an example, we have at least, I think there are 4 or 5 of our staff that are teaching at the General Surgery Review course, which is attended by all the 5s across the country. It's held in Toronto every year, or, well, it'll be virtual this year. But, the fact that a number of the panel is made up of staff from our institution kind of tells you that, the staff here are committed to being up to date, at being innovative, at knowing all the current guidelines, and sort of ensuring that their practice meets that standard, which is really encouraging, and gives us a lot of confidence that we're going to pass this exam, hopefully. Anyway.
Alex, there's a question about social activity outside the hospital.
Yeah, Nadia, do you want to answer that? I can too, but you can as well.
I mean, I don't know. I have to say, like, I came into residency thinking I would not have a life for 5 years, and thankfully I actually have been able to do a lot of the things that I've wanted to do. So I got lucky, and I came into a program with some really awesome people already in it. And so I have spent a lot of time hanging out with my co-residents, the seniors, the juniors. Ottawa is full of amazing opportunities for outdoor activities if that's what you're into. So my co-residents and I often go paddle boarding in the summers, and it's really easy to get out on the water. We all bought inflatable paddle boards, and that's sort of our like unwinding activity. There's the Nordic Spa, which is possibly the best place ever, not during COVID, but during normal times. So highly recommend checking that place out. And I don't know, we get together for dinners, we go out. Lots of places nearby. Prince Edward County is nice. There's tons of stuff to do, and I always find time to sort of get out and do those things. I think it's actually super important to get out of the hospital once in a while and see the world outside. What
And
about you, Alex?
that's a great question, actually. So we are very dedicated to social events within our, like within the residence. I don't usually head them. There are way funner people that are cooler that organize these things and not me. But essentially, once, actually, at least twice, we have a fall retreat and a summer retreat every year for the residents. And like the staff get on board with this as well as the fellows, because essentially for one whole day we just all piece out of the hospital. Like there are no general surgery residents in the hospital that entire day, so that it can be dedicated to our well-being. So for example,
That is a true story.
that is a true story. And the fellows, like I mentioned, step up. The fellows take the junior pager and take all the consults, do all the ORs while we're gone, you know, living it up for a whole day. And the events, I can recall all the events we've done through the years. So I put a picture in the presentation that was from archery tag. So we did archery tag one year for that. We did Nordic spa. We all went to the Nordic spa, paid for with meals, you know. We also did whitewater rafting. We've done a yacht, the boat, right? Yeah, we went on a yacht and went to like a private beach. I think it was a private beach or something like that. We also did, there was zip lining one year. There was outdoor water park, Calypso. Oh, so much fun. Yeah, so twice a year you just get to piece out of the hospital and just hang out with, you know, all your co-residents and have a great time, and the staff attend as well. Then there are other social events that, like I said, the cool people organize. So for example, Andre every year organizes a golf tournament, and then a pool party after that. There's also there's a Christmas dinner. There's always a general surgery Christmas dinner, as well as Department of Surgery dinner. And then I think there's more. Oh yeah, there's like a hockey tournament every year. There had been a basketball tournament. I don't know if they did it last year, but maybe it just got too competitive, you know. Some of these staff, they're anyway. So yeah, there's like all these, there's so many things you can be involved in, like more than you may even have time for, but lots of things to do in Ottawa, lots of things to do with, you know, friends outside of work as well as your colleagues. So.
I think we're getting close to time, but maybe Dr. Close-Ferry can take the last question. Since you're on the CARMS committee, it pertains a bit more to the unusualness of applications at this time. And I'm not on the CARMS committee, so I really don't have any guidance for you, but I would say that we all understand this is really unusual. And it's very difficult to be a candidate in this type of year. So certainly the understanding is there. But I'm sure Dr. Close-Ferry can give us more on that.
Or not.
Hello?
Come back, Dr. Kolsavari. Well then.
I can. Hey, I'm Tommy. I'm one of the
Tommy.
R5s. I'm going to speak up because Dr. Kolsvari may be away, and I'm also on the CARMS committee.
Yeah,
and,
actually, Tommy, sorry, I just want to say to the group, because Dr. Kolsvari is not the type to abandon, but actually she and I did a very high-risk surgery yesterday at our local heart institute, and it seems like the patient isn't doing well, and she left to go see them. So she sends her apologies. I'm sorry, I had a text message and I didn't see it till now. So maybe Tommy can answer.
Obviously, we won't have met any of the applicants, and they won't have any reference letters from surgeons they've worked with in Ottawa. But the only thing we can do is read the letters and the CVs much more carefully, which is already in process. I don't think our program description is up on the CARMS website, but I think the statement, the way we ask for the personal statement essay, will be a bit different, just so that we can look for more specific things or can read them in more detail, so that there will be a bit more guidance there. So I think we are doing our best. We do know that it's going to be different. And yeah, we will read everything more closely. I don't know if that answers the question.
Probably the best we can. You know, as much as this is unprecedented for the candidates, it's pretty unprecedented for the program, to have to choose people in very different ways. And um, in some ways, I would also say in some ways it maybe levels the playing field, because when you're planning your electives, you can only do electives in so many places. And certainly, students who do an elective with us often have an advantage because we've met you. So this way, the playing field is level. So I'd have to agree with Tommy. It's all going to be about kind of your written statements and letting us know, what your passion is and what your passion is, why you want to do general surgery, and why you're interested in coming to our program. Okay, perfect. It's 9:02. As Dr. Colesberry said at the beginning, we certainly appreciate you giving up so much time, because I'm sure you have a lot of these sessions. We know we're not the only ones. So thank you for spending your evening with us. And we wish you all the best of luck in your applications.
It was great to meet you all through Zoom. Best of luck. We'll be really excited to see some of you hopefully next year.
I'm sorry I missed the end of that. I had to take a call, but I'm sure they did a great job. Sorry.
Thanks, Dr.
Yeah,
Colesberry.
I actually just saw your text message and I said,
Me
Dr.
too.
Colesberry has an emergency.
Sorry. So yeah, sorry about that.
Okay, oh, you didn't
But
have to
I'm
go
sure,
in. Perfect.
No, not yet. But I'm sure Danielle, or their website, there's our email address. For sure, feel free to contact me if there's any questions I can answer. Or I'm sure Alex would love all your emails as well.
Yeah, send them my way. You can put them in the chat if you have any other questions, burning questions.
Thanks.
Have a great night, everyone. Thanks for your time.
Take care. Bye.
Bye.
Yeah.
Danielle, do I stop? I think, did I stop? It says record. Oh, I just stopped.